So we have some time for questions. I'm going to invite the three panelists to come up, and you can either go to the microphones that are in the back there, or we can also walk around with microphones. So
is it okay to go? Okay. I think this question is for you, Dr. Patel. Some of us, myself included, have embarked upon a journey with Wegovy that slows down digestion. And when you think about bowel prep, what are the impacts and are there any recommendations?
Really good question. Really important medications that are increasingly be used for treatment of diabetes and other conditions that we now recognize slow down the GI system. And so the anesthesia societies as well as the GI societies are in the process rapidly of putting together specific guidelines for our patients to not only ensure that we achieve an adequate bowel preparation in the setting of these, but also safety of the procedure. Because what we're finding, for instance, when I do upper endoscopies and colonoscopies, is that normally not eating anything after midnight is perfectly safe, because then when I drop the scope down at 7 a.m., the stomach is empty. But for patients that are on these types of medicines, we're finding an increasing rate of stomach that still has undigested food in it from the meal prior. And that's the effect of the medication, in some ways intended. But obviously, we don't want that food to regurgitate up, go down the wrong pipes and cause aspiration. So Maureen, more to come on that, but we're in the process of putting together specific guidelines such that when we do our review with patients before the procedure, that's one of the high-risk medications that we look for, and we give specific instructions on how long to stay without food, whether there need to be any other dietary adjustments, and we're working with our anesthesia colleagues as to whether that medicine needs to be paused for a couple of days before the procedure for safety purposes. So more to come. Thanks for bringing that up.
Thank you for coming and helping us work through this. I had a question about saturated fats and what role, if you are not a dairy eater or drinker, and you love coconut options, how does that impact, just as for saturated fat purposes? How does that impact somebody with MSH6, for instance, asking for a friend?
I don't know that I've ever seen anything that specifically talks about saturated fat with MSH6 or any specific, genetic variation, or I think that's more specific than our research has taken us. So I don't believe there are any specific guidelines around that currently. I would say that in general, saturated fat is not an issue unless you're running into, overweight, other things that would become risk factors to increase your risk for cancer. But saturated fat in and of itself, we don't have specific recommendations around the consumption. Tell your friend.
Hi, Dirk.
For those of us who've had our entire colon removed, is a starch-resistant diet still beneficial?
I don't believe it would be, because that digestion in the colon is really where the short chain fatty acids. Do you have a different comment?
Well, yeah, this was a really thought-provoking study, because the hypothesis was, because of everything that Patty said, was that it should decrease colon cancer risk, right? So that's why they designed the study that way. And John Byrne and his colleague, John Mathers, probably had a similar reaction as they did initially with the aspirin data, which was, damn. But what was surprising is that the upper GI cancer risk was low. Why? We don't understand how that would work based on what she said. The goal was to have this delivered to the colon and be a prebiotic and to create this butyrate compound. So the reality is it was a well-designed study. We believe the aspirin results. And, I think we trust the design enough to believe the starch results. But the finding of why upper GI cancers was lower and not colon cancers, we don't have the mechanism or understanding for how that works. And that's really provoked a lot of work and interesting research in other kind of possibilities. So for instance, is it that the resistant starch kind of modulates or binds bile acid, which we know can sometimes promote carcinogenesis in the upper GI tract? Those are question marks. So Dirk, I'd actually say that if you can tolerate it post-colectomy, it'd be worth trying to increase your resistant starch content. And, over time, as we understand how and why it works, we can let you know if alternate anatomy would change that. Thanks for sharing your personal story.
Hi, thank you for all this awesome info. 2 quick questions. Is psyllium husk considered a resistant starch?
No.
Okay. Secondly,
Sorry.
No, it's okay. Intermittent fasting. I've heard good things about that for, cancer prevention in general. Is that something to think about for Lynch patients or no?
I don't, again, they haven't looked at it specifically in regard to Lynch patients. The intermittent fasting, they don't exactly know, again, the mechanism of why that's helping, how that's helping, whether that surrounds, regulating blood sugar levels, whether that surrounds different hormones and things that are released. They're not 100% sure how that's helping. And so, that's a question mark as well. And so they haven't specifically looked at it in Lynch syndrome that I'm aware of.
This is probably for Dr. Patel. I don't remember the exact figures that you quoted, but the noticing of polyps during a colonoscopy was about 40%.
Well, in terms of the proportion of patients who have polyps,
yes,
it really depends on which patient population you're talking about. For average risk individuals, so your friends or neighbors who don't have a family history of cancer, don't have a hereditary syndrome like Lynch syndrome, when they come for their routine screening colonoscopy at age 45 or 50, for men, we tend to find at least one possible precancer polyp in 45 to up to 60% of patients. And for women, maybe just a little bit lower than that. For Lynch syndrome, we actually don't have really good high quality data to know how many polyps we should expect. Just based on what we understand, as intuitive, right? Probably the younger patients will have fewer polyps. Probably the patients with MSH6 and PMS2 might have a lower chance of having polyps than MLH1 or MSH2. So in Lynch syndrome, we don't have those percentage sort of expectations like we do in the general population. And that is a kind of a big arm of some of the research that I'm working on with colleagues across the country to try to establish with larger numbers what benchmarks we should be aiming for. We have those in the general population, not yet for Lynch, just because each subset of Lynch sort of, probably affects the risk of polyps.
Okay. I think maybe I asked the wrong question. This would be of polyps that are there, how many are noticed during the colonoscopy?
Yes. So the miss rate.
Yes.
So these are studies that have been done both in Lynch syndrome and the general population. So imagine consenting to do a study like this, but where patients undergo 2 consecutive colonoscopies. So a doc does a procedure, they know they're in a study, they take out as many polyps as they see, walk out of the room, and then another doctor walks in and does another colonoscopy. The miss rate for polyps can be as high as 30% in those studies. And those are really the most kind of pristine conditions, right? You're being watched. Now, the good news is that the vast majority of polyps that are missed, this is data from the general population, are usually small polyps, that for folks that it might take 8 to 15 years to grow, probably not that big of a deal if a 2 millimeter polyp is missed. But in our patients, we can't afford to miss polyps if we can at all avoid it. And so those are why we do a lot of the things that we do to try to decrease that miss rate.
And then real quickly, of those polyps that are found, about 40% regrow.
Well,
that are resected.
Yeah. So about 10% overall could be incompletely resected. That's based on one study. There have been subsequent studies that probably estimate it around there. But that's on the data that we have based on the studies that have been done. Probably one last question.
Last question, and yeah.
I'm the last person up here, so that's good. I'm not sure exactly who to address this question to. I thought of Dr. Lynch, and so I thought I'd just throw this out here to you guys in case you have any perspective on it. There's a lot of discussion online about whether or not breast cancer is ever going to be added to a Lynch cancer diagnosis. And we were talking about this at our table earlier today, and I am just looking for more information on that. I'm not a typical colon cancer, endometrial cancer family. We have a lot of breast cancer, and it's just a looming question out there that I think a lot of us have.
I think I'm gonna end up perhaps being the best person for that. So I think that getting to the root of that is challenging. So when we are defining a hereditary cancer syndrome, we're doing that by looking at large populations and figuring out that, for example, Lynch syndrome is at risk of X, Y, and Z cancers. BRCA mutations are at risk of X, Y, and Z cancers, right? We're doing that by looking at large populations and what's happening more commonly within those groups of patients who have mutations. So those population studies haven't borne out that we should be including breast cancer as a at-risk cancer for this population. And I would say yet, right? That's an evolving process. And that, as you saw today, when we have multiple genotypes that we're looking at, lots of different variants, those cancer risks can be very different. And so when you take a larger group of women who have, or patients, who have Lynch syndrome mutations, and then you break it down into 4 different smaller subsets, I think it's just going to be harder to get you that answer. So for right now, I would say it's not included in our kind of typical risk approach. That being said, breast cancers are one of the most common cancers in the United States. And can women with Lynch syndrome still just get one of the most common cancers in the United States? Absolutely. Right? That we still have all of the risk factors for breast cancer that can make that happen in addition to Lynch syndrome mutations. So I still think that mammography and discussing it with your primary doctor about whether you're at increased risk, regardless of Lynch syndrome, is really important.
I totally agree with that. It's this pendulum, that initially we're like, no, it's definitely not a Lynch associated cancer. And I think, certainly with the emergence of multi-gene panel testing, I've had to sort of deal with a lot of these kind of surprising families, along with my GYN colleagues, my breast oncology colleagues, because they do multi-gene panel testing because there's breast cancer history. And there's a PMS2 variant or an MSH6 variant. And many of you that I work with, that's how we came to know one another. So then, there was some data that suggested, oh gosh, there is an increased risk of breast cancer in these 2 variants. But then once you really look at some of these other really strong risk factors for breast cancer and control for family history, kind of evaluate that, then it's unclear whether Lynch syndrome alone really drives breast cancer risk. But the importance is that family history, which might qualify you for more intensive surveillance on that basis. So I'm always humbled with what we'll learn in Lynch syndrome. So we might tell you an updated tale in the future, but that's where it stands now. So I think for the sake of giving everyone enough time during the break, we'll close here.
Yeah. So thank you to all our panelists.